want to thank everybody for being here today. That's awesome, and I want to thank our online audience as well. We had over 300 people register to be on today's program virtually from around the world, all right? And that's a great number. You hopefully made it to the exhibit room, and if you did, I just want to let you know that we had platinum sponsors today for this program from Bristol-Myers Squibb, Biogen, and Sandoz. Our silver sponsor was Memorial Regional Hospital, and our community sponsors are Sanofi, Alexion, Janssen, TG Therapeutics, and Horizon. Let's give them a round of applause. Also exhibiting, we have Acorda, Banner, EMD, Serono, Genentech, and Novartis. Thank you to them as well. All these companies recognize the value of the programs that we've been providing, and that's been very, very important, because without them, we couldn't be doing the programs, and without you all, we could not be doing the programs. I wanted to recognize two people that are in the audience. One actually is not here right now. Maria, you here yet? Maria is here, great. And is that Maria Z? Yeah, you are here, great. Okay, perfect. So for everybody online, you can't see, but you just have to listen to what I'm about to say. We have Mr. Michael Mayette. Michael, raise your hand. Everybody see Michael? Michael has been a self-help group leader or support group leader for the National MS Society for, I don't know, way more than 20 years. Let's give Michael a round of applause. I know that Michael's doing it from that long ago, because when I was first diagnosed in 1998, his was the first group I attended. And it meant a lot to see what he was doing for the National MS Society, and he's the reason, he was the catalyst for me to be doing the things that I do. So I want to thank you personally for that. Thank you. And Michael, it's wrapped in bubble wrap, and I'm going to need your wife to come up and get this, but this is a plaque for you to show the recognition that we are giving you for what you do for the people with multiple sclerosis. Maybe we could take a picture of him. Hey, somebody take a picture of Michael with holding the plaque, all right? All right, next, Maria Zaldivar. Maria has been running a group in Miami for over 10 years. And I know that very well because I and two other women were co-facilitators of that group for more than 10 years. And when we stepped down, Maria took over. So I want to thank Maria also for all the work that she's doing for the MS community, especially down in Miami, where there are no other support groups for people to get the help that they need. And so Maria, if you don't mind coming up, this is for you, and thank you very much. All right, cameras, can you see it? Zoom on in, there you go. That's what Maria's getting. Okay, perfect, thank you. We have Dr. Adnan Subei. Dr. Subei earned his doctorate in osteopathic medicine at Lake Erie College of Osteopathic Medicine in Pennsylvania. He completed a fellowship in neurovisual disorders, clinical neuro-ophthalmology, followed by, this is like a tongue twister you gave me, right? Followed by neurology residency at Michigan State University Department of Neurology and Ophthalmology, Sparrow Health System. Got it. Okay. Upon completion of his residency, he pursued a neuroimmunology fellowship with emphasis on neuro-ophthalmology at the Cleveland Clinic Mellon Center for Multiple Sclerosis Treatment and Research. And Dr. Subei is going to come up and he's going to speak with you also for about 35 minutes and 15 minutes of Q&A. He will be speaking about visual problems with MS and recognizing MS relapse and recovery. Come on up, Dr. Subei. Thank you.
Hi, everyone. So happy Saturday. It's good to see you all. It's been a couple of years since I've been on a stage, obviously COVID. To paraphrase what he said, so I'm going to distract you for 35 minutes as you're waiting for your meal, because it's probably close to lunch. And I'm sorry about the photo in the flyer. He had my high school photo. So, all right, so we're going to talk about MS relapses and visual problems in MS. Here we go. So first, going over relapses and what relapses are. quick overview, just to let you know, lay the land, is that MS is an autoimmune inflammatory disorder of the nervous system. It usually starts in the periphery, meaning elsewhere in the body and in the bloodstream, and then it enters the brain central nervous system, and that's where the destruction happens, and the attacks and the relapses and so on. So it's important to sort of understand the mechanism that's happening behind what we're experiencing. And typically in a course, you'll see that someone would have, starting off with a semi-normal MRI brain, maybe they have a single lesion or so, and then they develop lesions over time, and those are areas where these attacks happen. And so when the attack happens in the brain and we experience it in our body, that's what we call a relapse. And so as you're seeing here with the MRIs, so you're seeing the initial and the follow-up showing more lesions developing over time. And then sometimes when you catch someone as they're having a relapse and you scan them and you give them contrast, so then you're seeing enhancement of the lesion on contrast. So as you all know, MS patients can develop many symptoms, fatigue being the most common, cognitive changes, depression, mood changes. Then you have your sort of sensory motor symptoms, numbness, tingling, weakness. You can have pain, vertigo, diplopia. So the list goes on. And then you have less common symptoms that can happen at the same time. Now, what's important is for us to recognize in what context these symptoms occur. Because as you know, as MS neurologists, is we often get patients who are asking about, do I have MS because I have these symptoms? And as soon as I go to Google and I put in my symptoms, MS shows up, as the first thing. And so, yes, you can see a lot of these symptoms, but they have to come in a certain way for us to say that this is actually MS. So, as neurologists, we love localization. Everything is about where in the brain, where in the central nervous system is the problem happening. So some typical locations for relapses, and so if you have a location that's sort of in the top part of the brain where the sensory motor cortex is, or a little bit lower than that, and so you can develop numbness or weakness within the brain. If you sort of affect, and which is relatively rarer, but if you have temporal lobe lesions, then that could affect speech, especially if it's on the left side of the brain. If you develop lesions in the back part of the head, and so some patients may experience vision loss. Lesions that are sort of lower within the brain, so then patients can develop double vision, imbalance, vertigo, dizziness. And then lesions that affect the optic nerves can cause vision loss, although it'll be in that eye where the optic neuritis has developed. And so, and again, I oftentimes get asked by patients is, show me that lesion that caused the symptoms that I have. And so sometimes we can, and sometimes we can't. Why? I will show you. In a few slides, not now. So when we're going over the spinal cord, so then whether it's the cervical spine in the neck or a little bit lower in the thoracic spine, so lesions that occur along the spinal cord can lead to numbness, weakness, imbalance, that MS hug that patients feel sometimes, bowel or bladder dysfunction. And so we have a very specific definition for what a relapse is. I showed you the locations and how things happen. This is taken out of the National MS Society website, and so if you wanted to sort of define what a relapse is, and I often teach this to residents and other physicians who are training to become MS neurologists, is the first thing is that it has to be a new symptom or worsening of a chronic symptom, okay, that no two exacerbations are alike, and so it has to be something that's different within 30 days or so, and it has to last continuously for more than 24 hours. And so those symptoms that happen off and on, so let's just say right now, as I'm talking to you, my left arm went numb for a few seconds and then it went away. And then later this evening, my left arm gets numb, again, a few minutes, it goes away. That's not a relapse. This has to be something continuous, nonstop, for 24 hours at least, if not longer sometimes. And then the last thing is, which is key here, is the absence of any infection or other explainable cause for the symptoms. So if all of these are met, then we say that this is a relapse. And this is what we actually go by when we're designing clinical trials so that we can get treatments and medications approved for MS patients. And so this is this helps us sort of distinguish what's a relapse and what's not a relapse. And I've had many patients who develop relapses that don't really fit this. But for the most part, most patients, this is sort of what they go through and what we consider a relapse. So to show you this in a graph temporally over time, and this is just completely hypothetical. And so if symptoms start to develop, they kind of worsen over several days, and then we're at their peak, and then they last for several days or weeks, and then you start to give a treatment, and then they start to sort of come down and get better over time. And that makes sense because the pathophysiology of MS is inflammatory. And we know that inflammatory conditions take time to develop. So it's not like a stroke where all of a sudden someone collapses because of symptoms. The inflammation builds up over time, which is why it takes a while for the symptoms to get stronger. And that's why we say the 24-hour rule is because it takes time for symptoms to develop. And then the duration of it, that depends on the severity of the relapse or the attack. And then you get an improvement afterwards, which may be immediately as you're starting a treatment, or there might be a delay because, again, the treatment decreases the inflammation, which then leads to repair and healing. And so there's always a delay when it comes to neurological recovery. And some patients can recover within days, and some patients within weeks, and some patients even months. So I often get patients who have developed relapses, and they ask me, hey, doctor, it's been a month or two, and I still don't feel like I'm back. And I tell them is that, listen, you're still within that window of expected recovery. So continue with therapy, continue with rehab. We have time for things to get better. So then what about MS over the years? And this sort of goes a little bit beyond the scope of this talk, but I wanted to sort of show you what it looks like in case you're not familiar. And so I showed you the model for one relapse in terms of the worsening and then it getting better. So patients can develop a few or multiple relapses over time. This is completely hypothetical again. And then the number of relapses decreases as time goes on. And then at some point, there's progression that starts to build up and increase over time. And oftentimes, it's related to the relapses that patients develop because relapses can increase progression. But then we also know that progression sometimes can happen independent of relapses. And then, as you scan people over time, and this is, let's just say, someone completely who's not on treatment, and so then their brain would accumulate more lesions as more relapses develop. Okay? So then, this is back to the whole idea about what I told you, is what part of the brain is really affecting my symptoms. I want to know where the lesion is. So what I'm showing you is a DTI image, diffusion tensor imaging. And that's a type of scan that's not done commercially. But this shows us the tracts within the brain. So what you are seeing here is all the different wires that are within the brain. Why am I showing you this? I'm showing you is the amount of wiring that's in the brain. And that's one of the great things about the brain is that you have a lot of wires. And so if you do develop lesions or attacks within the brain, you still have other wires that can sort of function. So then as you're accumulating relapses within the brain, you sort of get an appreciation for how many of those tracts are affected as more lesions develop. And the more time goes on, then the more lesions you acquire. And so then there are symptoms that patients develop that are not directly linked to a relapse. And those are things like fatigue, memory loss, cognitive impairment, mood disorders. Why? Because the networking and the wiring in the brain is so complex that not a single lesion is going to do it. But if you accumulate enough lesions over time, then that's going to slow down the process. And that's what I'm showing you here in the MRI between the one on the left and the one on the right, where the more lesions someone develops, then you would start to expect some of these symptoms to occur. A different analogy that I like to give patients is the difference in highways. And so if, let's just say on the left-hand side, you have a brain that has many lanes. And so if we were to do construction on a few of those lanes, you still have enough where traffic can flow and you're not going to have a lot of problems. Now, compare that to the the spinal cord. So you really just have almost a 2-lane highway. And so if you develop a lesion or you do construction on one lane, then it's going to be a real problem in the spinal cord. And this is why the brainstem, lower part of the brain, and the spinal cord is less forgiving. And when we see lesions develop in the brainstem and in the spinal cord, we need to be very aggressive about treatment, because you can see it here in the screen, is that the patients will certainly have symptoms, and their disability chances increase significantly. So then, what are some things that are not consistent with a relapse, or things to look out for? So when patients tell me stories, there are certain things that I'm looking for to make sure that this isn't like a false relapse. So one thing is symptoms that are consistent with your typical viral illnesses or any kind of symptom. So fever, fatigue, malaise, just generalized weakness, those are not consistent necessarily with a relapse. And so it sort of should trigger that there's something else going on, okay? And then when patients come into the hospital, and my colleagues frequently will call me up and tell me, hey, this patient's here, and she told me that it's her typical relapse, and she's back. There's no such thing as a typical relapse. When it's the same thing over and over again, then it should sort of make you think that this is a pseudo-relapse, or a worsening because of something else, not because of true inflammation. Because if you think about it, with all the pictures of the MRIs that I've shown you, the lesions can develop in different parts of the brain. It's all random. That's why not one patient has the same symptom as another, because everything is random. So then when something becomes repetitive, the same symptoms over and over again, that's less likely for it to be a true relapse, and more likely that it's a pseudo-relapse. It doesn't mean that we're not going to address it. It just means that we need to address it in a different way. Because why is it so important to figure out what's a relapse and what's not? Because it changes our treatment overall for the MS. When we put people on disease-modifying therapy and these anti-inflammatory medications, I need to know, do I need to change that treatment, or is this something else causing the relapse that I need to address and not change the current medication? The other thing is pain. So pain is very common in MS, and I get it. A lot of patients have pain, and we often talk about it during our visits. But isolated pain is a bit unusual. And so usually patients develop tingling, numbness with the pain, or weakness with the pain, or vision loss with the pain. But when it's purely pain, low back pain, or just eye pain with nothing else, it's unlikely for this to be a relapse. And so it is hard sometimes to really know whether this is a relapse or not from a patient's perspective, and I understand that. That's why I tell them is that talk to me first. Let's try to get this. So I'll give you an example. Is I have a patient who comes in with an episode of eye pain maybe 3 times a year. And I told the patient, there is no way you're having a relapse 3 times a year, and then goes into the hospital and gets steroids and the whole thing. And we got to cut down on the amount of steroids that you're getting, because I really don't think that these are true relapses. So we've kind of made an agreement so that I get called first, so when we talk about the symptoms, so that way we're not just jumping onto something that's not necessarily needed. And then we're bringing that back is the whole intermittent symptoms. And so if someone is developing symptoms and they are questioning whether this is a relapse or not, sleep on it till the next day. If the symptoms are still there, continuous, it's been a full day, then I say, okay, this may be a relapse, it needs to be addressed. So, and I get it, it's hard for patients to have symptoms and just ignore it for 24 hours, because every minute feels like an hour, and I understand that concept. But at the same time, with MS, when we talk about, like, I want to treat you now means over the next few months or weeks. And so it's not like a stroke where we're saying that you need a treatment within 3 hours that I need to give. So that's why in MS, there's no true emergency for the most part. And then rapid improvement. So we often get patients who come into the hospital. My partners will call me and tell me that, hey, I have one of your patients, and as soon as we gave steroids, the next day they were good, all the symptoms went away. there's a good chance that that wasn't a true relapse because, again, that whole inflammation that kind of goes away. And so, yes, it can happen. I'm not saying that it can't, but there's a good chance that it wasn't a true relapse if the symptoms go away immediately as soon as the steroids are infused. So, what do you do when you have a relapse? Call me, and then we'll do the typical screening. And so then, we'll check blood work, we'll do a urine analysis. If it's something to dealing with breathing problems, shortness of breath, we'll do a chest x-ray. And then if these are negative and you have symptoms and we don't have another explanation for it, you didn't run a marathon the day before, so then, we'll give steroids, or maybe if it's severe enough, we'll do plasma exchange, and so on and so forth. So then we'll address this as like an official relapse. So then what about, do we need to go to the hospital every single time we have a relapse? So actually, most MS neurologists will tell you is that we try to keep our patients away from the hospital as much as we can, because obviously being in the hospital increases the risk of acquiring other infections and having other complications. And so the more we're able to address relapses outside the hospital, the better position we'll be in. And so what I tell patients is that if the deficits are severe enough, and so let's just say that someone loses vision loss, gets vision loss, and they went from seeing 20/20 so that they're seeing 2400, or they can't see at all. That's pretty devastating, and we need to treat them more acutely because, in the outpatient world, it's a little bit slower. It takes time for us to put orders in and then get authorizations and scheduling. So then we'll say, okay, go to the hospital and let's just treat you real quick. Okay, but if it's something that the severity can sort of wait for an outpatient management, then let's do that and let's wait. The other thing is safety concern. Let's just say that this is a relapse that's causing severe weakness in the legs, where it's affecting ambulation, there's a risk of fall and injury, and we say, okay, no, you know what, let's go to the hospital, and it's better to do it that way. And then finally, if we anticipate a lot of rehab and we need acute rehab, then it's much, much easier to get it through an inpatient admission rather than it being outpatient. I could tell you that maybe I've been successful 2 times in my career of getting acute rehab to someone who's outside the hospital. It is very challenging. Not impossible, but can be done. But usually is the best way to do it is through a hospital admission and then move on to acute rehab. What about imaging? Do I need to get an MRI every single time I have a relapse? No. So then this is where it's the opposite of what general neurologists do. And so, people oftentimes is, okay, you have a relapse, we need to get an MRI because if I don't see a new lesion, then it's not a relapse. That's not how it should be. You should go back by that definition of what we said a relapse is. And so if it's within 24 hours, continuous, no other explainable cause, new or worsening symptoms, it's a relapse. I don't care if the MRI showed a lesion or not, okay? But obviously if the MRI shows a lesion, then that helps. So in general, it's not needed. I have ordered MRIs though in patients with atypical symptoms. If there's something unusual about the story that just doesn't fit your classic relapse, then I'll say, okay, let's get an MRI done, okay? The other thing is rule out mimics. And so I have patients who also have risk factors for strokes, and so developing symptoms may mean actually something else other than MS. So in that case, yes, we probably do need to get an MRI of the brain so that we can, same thing about, the stroke, within 3 hours, you gotta treat, so there's an urgency to it. So in those situations, I tell patients immediately to the ER and we need to get imaging fast. So I guess to sort of tell you about that slide is that if your neurologist does not order an MRI, they're not necessarily faulted. And so we'll order MRI just depending on what the symptoms are and what the relapses look like. All right, changing course somewhat. So vision in MS. So we're going to go over the anatomy of the eye, and what I'm showing you here is an eyeball. On the left-hand side, you can see the pupil. So you'll see the cornea, the outer part of the eye, the anterior chamber, then you have your iris, which is the colored part of the eye, and then the pupil, which is the hole for which light enters. It goes through the lens, and then it goes to the back part of the eye, which is the retina, and then it becomes the optic nerve, and then we go back into the brain. So light enters, and it goes in through the pupil, and it hits the retina. And that's where your receptors are for color vision and regular vision, and then they transmit the signal through the fibers, the retinal nerve fiber layer, and then through the optic nerve. So we're going to talk about optic neuritis and MS now. And so this is inflammation of the optic nerve that can happen in the context of MS, but it can also happen in the context outside of MS. So symptoms, so typically if this is someone's vision, so when they develop optic neuritis, it's sort of like you're blurring the center of their vision or blurring part of their vision. And there's different variations of it where it can be just a little bit of a blur. Sometimes it can be worse, a lot more, and it's just like just a dark area that they can't see through. I should have probably dimmed the image a little bit because the vision does get dimmer. So most of the time, 2/3 of the time actually, the inflammation happens behind the eye. And that makes sense, because if you think about the length of the optic nerve, what are the chances that the inflammation is going to happen at the very tip of the optic nerve that you can see, as opposed to the rest of the optic nerve? And so most of the time, the inflammation happens somewhere along the course of the optic nerve, which means when ophthalmologists and neurologists look inside the eye, they're seeing a normal optic nerve, okay? It's not affected. That's because the inflammation is retroorbital, okay? But rarely you can have inflammation that happens at the very tip of the optic nerve where you are able to see it. And so then you can see an inflamed optic nerve with hemorrhages, blood, and edema and swelling, and that's what it would look like. Now, I'll be honest, if I do get someone who develops an optic neuritis that I can see through the eye, I'm thinking of something else other than MS. And then if I don't find other causes, yes, it can be MS. But it's just atypical, but it can happen. So then if someone at baseline has 20/20 vision, as they're developing optic neuritis and it's worsening over several days and they have eye pain, so then their vision slowly worsens, and that degree of worsening depends on how bad the optic neuritis is. And then they lose color, so when we check their color vision, they're not able to read the color plate. And then they might develop a visual field defect. And so maybe they're able to see this part of their vision, but then down here in the corner, they're not able to see as much. It just depends on the fibers within the optic nerve that were affected. And this is the visual field machine that we would test their vision with. Okay, so here's an example of an optic neuritis. So you have a patient who has 20/20 vision in the right eye, develops 20/40 vision in the left eye. So that's a worsening of about 3 lines. And then they, and I'm just showing you the eye chart. Then they decrease poor color vision, and so they're able to read 10 out of 10 plates in the right eye, but the left eye can only, they can only do 1 color plate out of the rest. And then when you do their visual field, you can see that they're not able to see out in the periphery of their vision. So then there's the other thing is the pupil's reaction to the light. And so if you look at the eye right now, the pupil size, you compare it to the other side, which is a little bit bigger. That means that eye is not receiving light the same way as the other one. You go back to the other eye, and this looks smaller. You go back to the other one, and it's bigger. So that's what we call a relative afferent pupillary defect, or RAPD. Anyway, nerdy talk. So then when you scan the brain, so you will see inflammation and enhancement within the optic nerve that's behind the eye, and it fits. So this is a retroorbital optic neuritis in the context of MS. And then when you look at it from a coronal picture with the patient looking at us, and so you're able to see that there's a signal in the left optic nerve that wasn't there in the right. So, we treat optic neuritis just like we treat relapses with IV steroids. So I want you to ignore the orange arrow. Look at the green arrow. So in someone who has MS, we will typically do steroids for 3 to 5 days, and that depends on the severity of the vision loss or the severity of the relapse. Most of the time, we don't do a taper afterwards. We don't need to, because the inflammation, when it comes to relapses related to MS, it's pretty responsive to steroids, and it doesn't need a taper. So I made a dotted line to show that sometimes we will do a steroid taper, and it'll go on for a week or so afterwards, and there's no specific guidelines on how to do it the right way. Now, in the orange, when it comes to optic neuritis related to neuromyelitis optica or MOGAD, which are diseases that are cousins of MS, they sort of look like MS, but they're not. Those relapses tend to be more severe, and the vision loss is pretty devastating. So it's a little bit different than MS. And so we are more aggressive when it comes to that type of vision loss. And so we'll probably do IV steroids for 5 days and then continue with a very long oral taper over a couple of months. Because what we've realized is that when we taper steroids quickly, the inflammation comes back, and it comes back with vengeance, like pretty bad. So we want to be very aggressive when it comes to treating relapse and vision loss related to NMO and MOG. Double vision in MS. So, you got to think about the visual pathway in two different ways. One is the eye is like a camera that sees everything. But then you got to move the camera around. And so that's where you have the pulleys that move the camera right and left, up and down. And so we have different pathways that do that. And so within the brainstem and the back part of the brain, the cerebellum, we have different cranial nerves that do that. And so cranial nerve 3, 4, and 6 are within the brainstem. And we get wiring that goes from the brain down to the brainstem, from the cerebellum to the brainstem, and then eventually it goes out and it goes to those pulleys that move the eyes. So when you're sort of looking at someone, we know that the 6th cranial nerve moves the eye out, so it helps us look out. The 4th cranial nerve, it helps us move the eye down and out, looking down like that. And then you have your 3rd cranial nerve, it helps us look up, down, inwards, and then it'll also control the pupils. Okay. Now I'm simplifying things a lot here, but there's a little bit more to the tracks and the pathways that do this. So when someone develops a problem related to that mechanism that moves the eye around, what they develop is double vision, and that looks like that. So the pictures may be side by side, one on top, or it could be off at an angle, and that depends on which part of the wiring has affected the patient. And so when this happens, we sort of address it, and depends on in what context it is and what's happening, then we'll decide on the treatment. And so most of the time, when relapses happen and cause double vision, they will resolve with time. And so it's not that common for someone to be left with chronic double vision, although it does happen. So we will still treat it like a relapse, and we would give IV steroids, plasma exchange, depending on the severity of the relapse. But then let's just say that someone is left with a chronic double vision, or a double vision that we're going to expect they're going to have for several months or longer. So then we measure the degree of double vision. I don't practice neuro-ophthalmology anymore, but the neuro-ophthalmologist will measure the degree of their double vision, and then they might, if they have glasses already, they'll put on a plastic prism on the glass, and then and that temporarily will help the patient with realigning the eyes. And then if, let's just say that this is something that's going to last a little bit longer, they can create prisms within the glass itself, so that corrects a chronic double vision. And then sometimes, and rarely, is you might need to go the surgical route and correct the double vision by shortening some of the muscles or changing their insertion point, so that way it corrects for the alignment. But I could tell you that most MS patients who develop double vision, it's going to be either 1, 2, or maybe the third, which is the prisms. And so it's very rare for us to go the surgical route in these situations. All right, nystagmus. I don't know if any of you have heard of that word. So nystagmus. So what nystagmus is it's a drift in the eye. And so if I'm meant to look at a target, then my eye would drift away from the target, and then it corrects and fixes back. And then you get another drift, and then it corrects back. So that's what we call nystagmus, is that drift from the desired point of view and then the correction backwards. All right, look at these eyes. And I'm showing you the drift and then the correction back. So nystagmus comes in different ways and different characteristics. There are some that have jerk nystagmus, some that have pendular nystagmus, some that are gaze-evoked, some that are in primary position, some that are when you look down, downbeat or upbeat. We don't need to know about the details of that. Just know that this can happen in patients who have multiple sclerosis. Okay, so then the typical symptom that someone would develop if they were to acquire nystagmus is what we call oscillopsia, which is a sensation of motion or movement. And this is what it would look like. So their vision would shake and they're unable to sort of see things in focus. And it can be pretty disruptive. The good thing about this is most of the time, it's, again, something that resolves spontaneously over time, so they're not left, but there are patients that are left with this, chronic nystagmus. So we don't have any medications that have been proven to help with nystagmus. Proven meaning in a large clinical trial and have received FDA approval for treatment of nystagmus. But we have some medications that we have tried to see if it works in treating nystagmus. And so, we tried Namenda, which is used in memory loss. We've tried gabapentin, 4-aminopyridine or dalfampridine. Chlorzoxazone is a muscle relaxant, baclofen, clonazepam. We give it a try, and then we see did it help or not. And so it's a trial and error. And it may help in one patient, another medication may help in another, or maybe it won't help at all. So it just depends. Nystagmus is pretty challenging to sort of treat. Then I want to touch on positional vertigo. Why? Because it's a very, very common cause of vertigo. So common that actually the most common cause of dizziness in MS patients is this, and not really MS related. And so behind each ear, we have 3 tubes, semicircular canals, that sort of tell our brain in which direction we're moving. And there's liquid in that flows through. So when we turn our head, then the liquid flows through these tubes. And sometimes you can develop crystals within there that then they'll move in a certain direction, and they will cause nystagmus, and they will cause dizziness and vertigo when someone moves. So the typical story is that, hey, doc, I'm usually okay, and then I bend over, roll over in bed, do something, and then I get this real quick vertigo. And when you ask patients, they'll tell you that, I feel like I'm dizzy the whole day. But when you pin them down and you say, I know you're dizzy all day, but that actual spinning, how long does it last? They're like, it's just like a few seconds or minutes when I move. So that's that. So that's positional vertigo. And so a person might feel bad and icky the whole day, but the actual oscillopsia is going to be for a brief moment. So then what you would typically see is when we test the patient in the clinic, we put the patient down, lay them down, and so as soon as you do that, you start to see the eyes jumping and you're getting that nystagmus that's torsional related to that exercise that we just did. That's what we're looking for. So if I test someone while they're sitting and their eyes are normal, and I lay them down, and then they develop nystagmus, that's BPPV, which is very treatable. And the treatment for this is an exercise where you kind of turn the head to one side, turn the other, roll them over, have them sit up, and that's the treatment for BPPV. It's actually not a medication. The medication will only dampen the effect of the vertigo, but they don't take it away. So if I had blurred vision, then what do? The first thing you can help us out is tell us which eye. So as soon as you start to experience blur, cover one eye. Is it blurry? No. Cover the other one. Is it blurry? No. Oh, it's blurry when both eyes are open. Okay, that has to be something related to alignment. But blurry, yes. Blurry, no. So this might be a problem in that eye. So that's how we troubleshoot vision loss. So it's very important when you call the neurologist, Tell us which eye is the problem, and you can't cover one eye. You have to do both, okay? Not both at the same time, then you can't see. So then you need to tell us, is it constant or intermittent? So that's very important. And so non-stop ever since it started, or it's like off and on. So that's important for us to know. And then when did it start, in what context, and then is there pain also, because that helps us with the troubleshooting. All right, let's wrap this talk up.
Thank you very much, Dr. Subei.
Thank you.
No, you're in conclusion still.
I was concluding.
Okay, conclude, go.
Conclude. You got to understand what a relapse is, the duration, the symptoms, no underlying cause or infection that's causing this. You got to understand the management in terms of hospital, no hospital, steroids, no steroids, and the duration. So that varies depending on the severity of the relapse. Visual symptoms in MS. So you can develop vision loss from optic neuritis. You can develop double vision or nystagmus related to MS. And then how we treat it and troubleshoot it, we just talked about alternating the eyes and figuring out where the vision loss is from. Done.
Thank you very much. First one, why does physical exertion cause MS relapse?
So physical exertion, it's not your typical, so you have to exert yourself beyond your body's capacity. And so it's sort of similar to Uthoff's phenomenon, which is overheating the body, and that will temporarily, and I wouldn't call it a relapse. I would call it most likely a pseudo-relapse, because it's a temporary worsening. You're basically overusing your nerves. And so if the brain's output to the body is maybe 80%, 90% in MS or something, so you're overusing your body, so your brain output decreases to like 60, 70, and so that difference is what you notice with, I feel tired and weak because you overuse. It's more of a stamina issue, but it's not a true relapse.
If a person gets an MRI and their MRI shows no worsening, yet physically they are greatly worsening, or that cognitively they're greatly worsening, what's happening?
So it could mean a sign of progression. It depends on the tempo of the worsening. So if this is something that's been happening over several months, then or several years, then yes, this could be a sign of progression. If it's worsening that just happened within a week and someone was fine the week before, then it could be related to a relapse or some activity that's not captured on the MRI. So that's where a discussion with the neurologist has to happen.
Great, thank you. Next one, oral or IV steroids, which would be better to use for optic neuritis?
Optic neuritis.
Yeah, okay, optic neuritis,
so
right, there you go.
What we've learned is the key word is high dose. Okay, so if we are going to do oral, it has to be high dose. It can't be lower because it's sort of like a tease to the immune system, and sometimes relapses and inflammation can come back real bad. And so as long as you're doing high dose, then it doesn't matter IV or oral. I could tell you this, is that in some patients that, let's just say I had someone who was stuck in the Keys and they had a relapse and they needed treatment, and there was no way for me to set up IV steroids. So then I sent them to the pharmacy oral steroids, and I sent them a lot of prednisone. You will get a call from the pharmacist and they think you're crazy, but you're not. You're just trying to treat with high-dose oral steroids.
Do you recommend turmeric as an anti-inflammatory?
Sure.
Okay. Are visual floating waves of light, I guess floaters?
But most likely those are migraines. And so those are what we call photopsias. So you get that scintillating scotoma that looks like a zigzag, or it looks like a crescent or sparkles. Unlikely for this to be optic neuritis, although can't be sure. The other thing to make sure that it's not, it's a retinal disease, because retinal disease will also give you those photopsias.
Okay, thank you. Next one. Is it common for MS-related visual changes, blurry vision, double vision, etc., to come and go, meaning blurry or double vision, 1 or 2 days, and then back to normal?
Most of the time when that happens, that means that there's an underlying process that happened long ago. So it's not uncommon that you've had, let's just say someone has had optic neuritis back in the 80s, 90s, what have you. And then now they sort of get this temporary worsening that happens. And that, again, has to do with that whole stamina of how much power is going from the brain to the optic nerve. And so when someone is tired, fatigued, exhausted, sick, then you decrease the power, so then you develop worsening of symptoms, you improve again, you relax, and then power goes back.
Great, thank you. Next online question is, how close are we to remyelination?
Close, I hope. We have several studies that are ongoing for remyelination. Some have worked, some have not, and so we're still trying to find the best agents to help us with remyelination.
So have you had patients who cannot be corrected, meaning their vision cannot be corrected? Have you had MS patients whose vision cannot be corrected?
Exactly, yes. So this is an important concept, is when we as neurologists test vision, we are looking for best corrected visual acuity, which means that we need to correct you as best as we can, and then what are we left with? That determines the retina and optic nerve function. So if you have vision loss or change that is correctable, not neurology. Okay? So yes, optic neuritis, if you are left with poor enough vision, then you will be left with a deficit that's not correctable.
How do you determine, is it from a MRI that you find out about the optic neuritis? Does it show on your MRI, like when you do your brain MRI? Is that how you determine it based on the symptoms?
Yes, it can. So you can do an MRI of the orbits, and then that gives you a magnified view into the optic nerves. But I like to rely on my clinical judgment. And so if I see someone who has lost vision, they're not able to read the eye chart the same way, they've lost color, their visual field is down, if all these elements fit, and you tell me the MRI is normal, I don't care about the MRI. This is optic neuritis.
Thank you. Over here, please.
Good afternoon, and thank you for coming. One question is, if you have imbalance, is it strictly from your eyes or is it weakness?
So one more time.
Yeah, it's imbalance. So if it's strictly
Imbalance.
Yeah, and also can you have exercises to eye exercise to help you with your imbalance?
Okay. All right, so imbalance is a little bit tricky. So there are 5 things that are related to balance. So my ability to stand right now is dependent on 5 things. 1 is strength. I have to have the strength enough to be able to stand. If I am weak, I'm not going to have good balance. 2 is sensation. I have to feel the floor under me to be able to have good balance. If I don't have good sensation, then things will not be so balanced. 3 is coordination. I should be able to move my arms and my legs smoothly without ataxia to be able to walk without balance issues. 4 is vision. I need to be able to see in order for me to walk with balance. The analogy to that is if the lights are off, you have a hard time walking. And then 5 is frontal lobe. If I don't have a strong frontal lobe, then I'm not going to be able to coordinate all of these things to be able to walk. So when someone comes in with imbalance, that's what's going through my head. I'm trying to figure out which one of those is off. And oftentimes it's not one, it's many. And we try to address what we can.
About 40 years ago, I'd been diagnosed with an internuclear ophthalmoplegia, and a lesion was found on my brainstem. In recent MRIs, no lesion shows up in the brainstem. Is it possible for damage that had occurred for a lesion to disappear?
Yeah, that's a great question. So I didn't go over internuclear ophthalmoplegia, so I only got 35 minutes to talk. So, but anyway, so the medial longitudinal fasciculus (MLF) is the pathway, the wiring that goes from the pons up into the midbrain, and that connects the 2 cranial nerves so that you're able to move your eyes together. Remember that slide that I showed you with the highways? That pathway is like half a lane. So if you have a lesion within that, you will develop an INO. Many times we don't see that on the MRI because it is so small that you can develop a lesion and not see it on the MRI. Lesions happen and go away. Yes, some lesions do go away, so you don't see it anymore.
Hi, you've been really informative. You were talking about inflammation, and I'm wondering, do you recommend anti-inflammatory meds as what I call maintenance medication?
The disease-modifying therapies are the best anti-inflammatory medications that are out there to treat MS.
Like what?
There's 22 of them.
Oh, okay.
Yeah.
Why is the double vision up and down instead of side to side?
It can be either. So it just depends on which wires are affected. It can be either side by side, one on top, or off at an angle.
Why does it's weird when it does that? Because I get the double vision that's up and down, like one on top and one on the bottom.
Yeah, that just depends on what part of the brain was affected that it would happen. Mm-hmm.
Okay, another one. Have you found MS to be weather-related?
Yes.
Why?
So we live in South Florida. So I could tell you is that from June up until September, I got a lot of calls for worsening MS symptoms, and that has something directly to do with the weather. Obviously, we know that heat exacerbates MS symptoms, temporary worsening, which is what we call Uthoff's phenomenon. And so if you overheat the body, the internal temperature of the body, so then you get this temporary worsening of symptoms, you cool the person back down, so then their symptoms get better. And so you should always anticipate those times when you're going to be in a situation where your body is going to overheat, and try to find ways to cool yourself.
It's funny because everybody gave a little giggle when I said is MS weather related. See? There you go. All right, we are done with the questions, and I want to thank you for being here, and here is your plaque.
Thank you
very much. Going to hold it up for the audience. Thank you very much. Plus, I just want to again thank all the supporters who I mentioned earlier. I'm not going to say all their names again. And I do have to thank greatly Orlando Production, my production team, who follows me around the country as we do all of our programs, handles everything virtual. And as you can see by all this equipment, it takes a lot to do all of this. All right, so let's welcome and say thanks to Orlando Production. And also, I have to thank all of you. All right? All of you online, thank you. All of you that attend our programs, thank you, because I couldn't do this if we didn't have people to do it for, right? So I do want to thank you all. All right, that's it. It's a wrap. Say goodnight, everybody.